This is PediaCast CME.
Welcome to PediaCast CME, a pediatric podcast for providers. And now, direct from the campus of Nationwide Children's, here is your host, Dr. Mike.
Hello, everyone, and welcome once again to PediaCast CME. It is a continuing medical education podcast for healthcare providers. This is Dr. Mike coming to you from the campus of Nationwide Children's Hospital. We're in Columbus, Ohio. It's episode 81 for November 16th, 2021. We're calling this one Supporting Children and Teens with Type 1 Diabetes Mellitus. I want to welcome all of you to the program. So we are exploring type 1 diabetes this week with an emphasis on the primary care provider's role in supporting children, teenagers, and families impacted by this common disease. Of course, we're going to review the important elements of type 1 diabetes, including epidemiology, pathogenesis, symptoms, diagnosis, and management, and we'll focus on innovative ways to support those impacted by the disease. For those of you who would like a deeper dive into diabetes, because really we could spend an hour talking about each component of the care of diabetes. But if you are interested in a really deep dive on diabetes mellitus in the pediatric population, we will have links to a whole bunch of up-to-date articles in the show notes over at PediaCastCME.org. This is episode 81. So if you have an interest in that and access to up-to-date, we'll have a lot of resources. We'll also have non-up-to-date resources. So if you don't have access to that, we will have some great free resources for all of you. So just head over to the show notes at PediaCastCME.org, and we'll have those all listed for you in the show notes for this episode 81. We are going to talk about a very innovative school-based type 1 diabetes program today called Diabetes Dash, and we'll also explore the impact the COVID-19 pandemic has had on the incidence and management of type 1 diabetes. So lots coming your way today, and to help us with the details, we have two terrific guests joining us in the studio. Dr. Aurelia Wood and Dr. Kajal Gandhi. They are both pediatric endocrinologists at Nationwide Children's Hospital. They are passionate about helping children, teens, and families challenged by diabetes. And in fact, they appeared on our podcast for parents, Plain PediaCast without the CME, back in July on episode 522 of PediaCast, and that episode was called Diabetes Dash. It's a great one to share with patients and families because we talk about the disease in plain language and consider the same school-based diabetes program that we will be discussing here today. And I'll put a link to that episode in the show notes as well. All right, before we introduce our guests, let's run through our usual quick reminders. Don't forget you can find PediaCast CME wherever podcasts are found. So in the Apple and Google podcast apps, iHeartRadio, Spotify, SoundCloud, Amazon Music, and most other podcast apps for iOS and Android. If you like what you hear, please remember to subscribe to our show so you don't miss an episode, and please consider leaving a review wherever you listen to podcasts so that others who come along looking for free continuing medical education credit will know exactly what to expect. Speaking of that educational credit, it's really easy to claim yours. Simply listen to the podcast, which you are about to do, and then head over to the show notes for this episode at PediaCastCME.org. You'll find a link to the post-test in the show notes. Follow that link to Cloud CME, take and pass the post-test, and the Category 1 credit is yours. We offer credit to many pediatric professionals, including doctors, of course, but also nurse practitioners, physician assistants, nurses, pharmacists, psychologists, social workers, and dentists. And since Nationwide Children's is jointly accredited by all of those professional organizations, it's likely we offer the exact credits you need to fulfill your state's continuing medical education requirements. Of course, you want to be sure the content of this episode matches your scope of practice. Complete details are available at PediaCastCME.org. We're also on social media. We love connecting with you there. You'll find us on Facebook, Twitter, LinkedIn, and Instagram. Simply search for PediaCast. And we do have a contact link over at the website, PediaCastCME.org, if you would like to suggest a future topic for the program. Also, I want to remind you the information presented in every episode of PediaCast CME is for general educational purposes only. We do not diagnose medical conditions or formulate treatment plans for specific individuals. Our discussion may contain only a portion of relevant information and should not be solely relied upon for the diagnosis or treatment of any medical condition. We do not cover every possible treatment option, and the treatment options we do cover do not include every possible use, precaution, side effect, or interaction. Also, your use of this audio program is subject to the PediaCast CME Terms of Use Agreement, which you can find at PediaCastCME.org. So let's take a quick break. We'll get our expert guests settled into the studio, and then we will be back to talk about type 1 diabetes mellitus. It's coming up right after this. Dr. Aurelia Wood and Dr. Kajal Gandhi are endocrinologists at Nationwide Children's Hospital and assistant professors of pediatrics at The Ohio State University College of Medicine. They each have a passion for helping patients and families impacted by type 1 diabetes mellitus. They're here to help us review this common condition, including pathophysiology, symptoms, diagnosis, management, and then we'll also explore an innovative school-based diabetes program called Diabetes in School Health, or Diabetes Dash. We'll consider the COVID-19 pandemic and the ways in which it has impacted the incidence and management of type 1 diabetes. And we'll explore the roles primary care providers and endocrinologists play in supporting and managing patients and families challenged by type 1 diabetes. But let's begin with a warm PediaCast welcome to our guests, Dr. Aurelia Wood and Dr. Kajal Gandhi. Thank you both so much for being here today.
Thank you so much. We're happy to be here.
Thanks again for having us.
Yeah, absolutely. And this is a great time to be talking about diabetes because it is Diabetes Awareness Month right now, correct?
That is right. And this past Monday, from when we were recording this, the 14th is World Diabetes Day.
Great. So we definitely want to raise awareness about diabetes. It's such an important thing to help our families with because there's a lot of life changes, and in order to maintain a great mental health and dealing with a chronic illness, there's just lots of pieces, parts, and it's important for all of us to have some good understanding. So let's start, Dr. Wood, if you could just remind us, what is type 1 diabetes mellitus and how does it compare? If there's a type 1, there must be other types. So just give us a little bit of a foundation.
Yeah, so type 1 diabetes is a chronic lifelong condition that occurs as a result of autoimmune destruction of the beta cells of the pancreas, which produce insulin. So this results in relatively subacute hyperglycemia, which progresses and to the point where patients are ultimately diagnosed. And we'll talk about what that looks like a little bit here. But ultimately, it's essentially a permanent loss of insulin function.
Yeah. So if you don't have insulin to bring sugar, glucose into the cells, then your body is going to have to find alternate pathways of making energy. And then there are byproducts of that can cause your acid-base balance to be off and then cause those symptoms.
Exactly.
So it's an issue of not being able to get the glucose into the cell because there's not enough insulin present. And then type 2 diabetes is a little bit different than that.
Yeah. So patients with type 2 diabetes are making insulin. Their body just can't respond to it. So we use the term insulin resistance in those cases. It is much more familial and seems to be run more in families than type 1 diabetes does, and often is associated with changes in weight and elevations in BMI, but sometimes just that family history and the right circumstance can also result in that picture.
And that's not the topic of today's podcast, but we are seeing more of that, right, in the pediatric population. I think when I was training, it was more like it was an afterthought in pediatrics, like, well, we'll let the adult world deal with type 2 diabetes, but we are seeing more of it, right?
We sure are. And initially when diabetes was identified, they called it juvenile diabetes, which they really meant type 1, because really type 1 presents at an average of 12 to 14 years of age. So most people that do have new onset, especially diabetes, are children. But we do know that people can present in the second, third, and even fourth decade of life.
Yeah.
Traditionally, type 2 diabetes is the most common type of diabetes worldwide and the one that most people are probably most familiar with and is more common in adults. But as you mentioned, we are seeing quite a rise in the incidence and prevalence of type 2 diabetes in the pediatric population.
Yeah, absolutely. And so let's turn our focus on type 1 diabetes, since that is what we are here to talk about today. And how common is this condition and who is affected?
Yeah, so it's, as you mentioned, one of the most common chronic conditions of childhood. The highest incidence and prevalence is actually in the Scandinavian region of Northern Europe. So most people worldwide that are affected with type 1 are Caucasian and from that background. However, people from all ethnicities, nationalities are affected. And so people around the globe and, of course, across our country are dealing with type 1 diabetes. There are about 1.6 million Americans currently living with type 1 diabetes, and about 200,000 or more of those are in our pediatric population, so being under 20 years of age. Each year, about 20,000 kids are diagnosed, and we are seeing the incidence go up steadily. And it's estimated that by 2050, about 5 million people in the United States will have type 1, with more than 500,000 of those being kids.
Yeah. And the incidence is increasing, right?
That's right. Yeah. And especially among populations that aren't from that traditional background. So we're seeing more kids diagnosed who are from African American, Hispanic, and Black backgrounds.
Throughout this podcast, I'm going to provide some resources on each individual component because type 1 diabetes is a really big topic. And so there's no way that we're going to cover everything in an hour. But Up to Date has some wonderful articles. And so the first one is Epidemiology, Presentation, and Diagnosis of Type 1 Diabetes Mellitus. And so I'm going to put a link to all of these as we go along in the show notes so that if you are interested in learning lots more about each of these individual topics that we'll be covering, we'll have those resources available to you.
Great. Another really great resource is the International Society of Pediatric and Adolescent Diabetes, ISPAD. So they put out our guidelines for management of type 1, type 2, cystic fibrosis-related diabetes, monogenic diabetes, neonatal diabetes. So really all of the different types of diabetes and go into each of those in depth. And there's some really great resources there for folks as well.
Yeah, and we'll put a link in the show notes to that resource too. So Dr. Gandhi, we had mentioned that there's an issue with cells in the pancreas that usually make insulin. So as we think about the pathogenesis of type 1 diabetes, what's happening?
Yeah, so we have a lot of studies investigating type 1 diabetes, and we're still learning a lot about what exactly causes type 1 diabetes. What we do know, as Dr. Wood mentioned, is that type 1 diabetes is an autoimmune condition that is caused by the destruction of insulin-producing pancreatic beta cells that is actually T cell mediated. What that means is that we have presentations of islet cells, antigens on what we call HLA, so human leukocyte antigen molecules to T lymphocytes. So it's an immune process. And so that complex system plays a pivotal role in the immune-mediated destruction of beta cells. And so there's a lot of genetic variability in HLA that affects your susceptibility to getting type 1 diabetes. And there's a lot of research investigating that. And so with that, there's also studies theorizing that along with the HLA susceptibility, it's a complex multifactorial disease that is a combination of genetic, environmental, and cellular factors. And so up to 50 to 60% of people with type 1 diabetes do have a high-risk HLA haplotype. With these environmental factors, cellular factors, and genetic factors, there doesn't seem to be quite a bit of evidence to say that there's this true association environmentally with the association of type 1 diabetes diagnosis. But some of those factors that have been studied include maternal age, obesity, beta cell stress, diet, introduction of solid food or breastfeeding, vitamin D consumption, and various introduction to viruses. And these are all drawn from 3 large longitudinal studies, observational, that include environmental determinants of diabetes in the young, the TEDdy study, the diabetes autoimmunity study in the young, the DAISY study, and the TrialNet pathway, which is what most providers are very familiar with, that investigates close family members of children with type 1 diabetes.
Yeah. In my mind, being a non-endocrinologist, I try to simplify things, and I think that helps me not only understand it, hopefully, but also helps me explain it to patients and families. So as we think about all of those different factors and you think about the antigens that are on the outside of cells, and it's our antibodies then that are attacking these cells.
Correct.
And so there are a lot of factors that can change what those antigens look like and what the antibodies are that are active at the moment look like based on recent viral infections, based on these other things that you had mentioned. So as you said, it's a multifactorial, it's complex, but we do think that there's a component for some people after viral infections if all the other factors match up. So you have sort of a genetic predisposition after a viral infection. Would that be a good way to put it?
I think that it's still investigational, and I think there's still a lot of that genetic susceptibility that we are studying. But there is some association with viruses and environmental factors that they're still studying. So I think there's not truly a strong association in that we can say that if you do have a certain virus or you have a certain environmental exposure that you will develop it or you have a certain percentage of developing it. However, there's a lot of research that remains to be investigated.
And it seems like genomic medicine may come to play a role here in terms of future discoveries of that susceptibility. So there may be someday that we could, run someone's genome and say, no, you are high risk if you get a particular virus of this happening, but we just aren't there yet.
Yeah, and there's a lot of other very investigational, actually very recent studies that talk about things like receptor advanced glycation end products, they call RAGE. They talk about endoplasmic reticulum stress, ER stress, which also plays a role in other inflammatory and immune conditions. And so this ongoing work is ever changing. And I think we're going to keep learning more and more, even 6 months down the road, 1 year, 5 years, and 10 years, that'll allow us to provide us more information on the pathophysiology and potential prevention of type 1 diabetes.
Yeah, which would be very important.
Absolutely.
Obviously. One of the links that will be in the show notes is also from Up-to-Date Pathogenesis of Type 1 Diabetes Mellitus, which is a whole article in and of itself. Let's talk about signs and symptoms then. So what happens in the body because we can't get glucose into the cell? We said that we use alternate methods of energy production, but then what does that look like from a clinical standpoint? A kid is presenting. When should we be thinking that type 1 diabetes may be the problem based on the signs and symptoms?
Right. So that's a great question. So as we had mentioned before, type 1 diabetes is a chronic destruction of beta cells that produce insulin. So over time, we have this relative state of insulin deficiency. So insulin allows our cells in the body to utilize glucose for energy. So as that level of insulin decreases, children start experiencing high blood sugars and with no real energy source for their body to function properly. And as that blood sugar rises, they don't have a real energy source. They start breaking down other sources of energy, including fat, which produces ketones. And we'll talk about that in a second. But with that increased blood sugar, they have symptoms such as increased urination, increased thirst or drinking, feeling hungry often, fatigue, sometimes losing weight because they're breaking down fat that ultimately produces ketones. Once they produce ketones, that's what actually allows them to become sick. And along with the high blood sugar, becomes more of an acute issue. And so that can progress to what we call DKA, or diabetic ketoacidosis. And that's a severe complication of untreated diabetes. Now, fortunately, we do have many providers who are screening for many of these symptoms in their well child visits or any other visits. And so fortunately, we're seeing more children earlier in their diagnosis, and we're not seeing as many people with DKA. However, of course, we do see children with DKA at diagnosis, but ultimately with treatment of insulin, they do just fine. Yep. And I will tell you that younger kids tend to present in DKA more often than older children.
Yeah. So because we can't get insulin, or because insulin is not helping get glucose into the cell, we're using fats. We have ketones that get made as a byproduct of that metabolism. And then the ketones cause acidosis, and then you're going to, breathe faster to try to correct that. And the sugar then builds up in the bloodstream, and that causes the a polyuria, then that's going to make you thirsty and you're drinking more. So that's kind of the reason behind that particular set of symptoms. So then how do you diagnose type 1 diabetes? Like from a primary care perspective, you have a suspicion. Maybe kids had weight loss. Maybe they're sicker than they ought to be with the whatever virus that they have. Or they tell you that they're drinking a lot and urinating often. How do you go about diagnosing this?
Yeah, so unfortunately, these symptoms, as we just mentioned, are very vague. And so these symptoms as polyuria, polydipsia, fatigue, not feeling well, losing weight could be caused by a lot of different medical conditions. However, of course, our wonderful providers are doing a great job with recognizing that this could be a possibility. So when they see a patient or a child in their clinic that could have that diagnosis, a good way to do that is just to screen their blood sugar. If you're fortunate enough to have a equipment to check a blood sugar, that would be great. And so typically a blood sugar above 200 is usually what you find when you're having these symptoms. And so a random blood sugar above 200 is a good way to just have an acute check to see if they're doing okay. Another way, if you are concerned, is maybe doing a urinalysis. And that allows you to know whether they're spilling glucose into the urine. So they're having glucoseuria in addition to maybe having ketonuria, which raises the acute status of their diabetes diagnosis.
Yeah.
A more non-acute way to diagnose diabetes is something called a hemoglobin A1C. And a hemoglobin A1C is just a measure of average blood sugar over 3 months. And that's something that you can send to the lab. And anything 6.5%. So the higher percentage is a higher average mean blood sugar. So 6.5% or higher is indicative of diabetes.
Yeah. And the reason that the hemoglobin A1C is high is because the excess glucose that's in the blood is sticking to the red blood cells?
Exactly. And then because of that red blood cell life, that allows you to have an average mean blood sugar over a longer period of time, and sometimes gives you more information than just one check of a blood glucose level.
Now, you had mentioned that you're seeing kids earlier in the stages of diabetes and at the time of diagnosis. So it would seem to me that doing a urine screen at a well checkup, just for the reason of screening for diabetes, because maybe they don't have any physical symptoms yet, but they may be at that 200 level and starting to spill a little bit of glucose into the urine. Maybe we should be doing urinalyses at every well checkup. What do you think?
Yeah, and I think that's something definitely, if you have a high suspicion of diabetes, I think it would be definitely informative. The kidney starts pushing out glucose around the blood sugar of 180 to 200. So once you're having those signs and symptoms, you likely will have glucose in your urine. You may or may not have ketones in your urine, but it's a good fast way to figure out if you are concerned about it. Now, glucose can occur and ketones can occur for other variety of other medical conditions. So we want to take that piece of information in the context of what else is going on with that child to determine the best way forward.
Yeah. But if it's a kid who's just beginning to have diabetes, they may not have a lot of symptoms yet, and you might catch it by doing a routine urine screen.
Right.
And it's non-invasive compared to getting a serum glucose and a hemoglobin A1C.
Right. It's very informative. It's easy to do in the office in the context of their clinical evaluation.
So let's say we see a child who we have suspicion, we get a urine, there's glucose there. We're going to confirm that and see what their blood sugar is and with maybe their hemoglobin A1C. And then we're going to probably send them to an endocrinologist, or we're going to call our friendly consulting endocrinologist on the phone. So where do we go from there? How is this treated in the beginning phases and then ongoing?
Yes, absolutely. I agree with you. So if you have a concern for diabetes and you get a urinalysis or a blood sugar and you're concerned about it, it's always important to, discuss that with an endocrinologist if you can, to determine the clinical context of the situation, to determine if this would indeed be diabetes. Typically, then we would advise to get an A1C for further information, and if they're having acute symptoms, to be medically evaluated quickly. And so if they indeed have diabetes, the way you treat that is, because you have relative insulin deficiency, you treat it with insulin. And so insulin is given through an injection, and it's a subcutaneous injection given underneath the skin, and you can give it through like a pen, insulin pen, or an insulin pump, which is attached to your body, and it's changed out every 2 to 3 days. And so When we get diagnosed, and this will vary depending on who is caring for you and what center you go to, but you will be started on insulin either by pens, like an injection, or through the pump. And so if you are started on injections, you're given a long-term insulin, a once-a-day insulin that's a basal insulin that typically lasts about 24 hours. And then you're given short-acting insulin that's given for blood sugar correction, insulin for your carbohydrates that you consume. And of course, when you are sick and ill and you need extra insulin to clear your ketones.
So really the mainstay of treatment, both acutely and ongoing, is going to be to provide the insulin that is missing. Dr. Wood, sometimes when kids present in DKA, they can be pretty sick. And so you wouldn't just start with a pen, right? There's
That's
more
right.
that you do. What does the management of DKA these days look like in the emergency department?
Yeah. So like Dr. Gandhi mentioned, many kids do present with maybe just hyperglycemia and symptoms in the office, but about 50% of kids do present with DKA because it is subacute and symptoms can be very vague. Fatigue, maybe a little bit of weight loss. But if it's summer and I've been doing soccer every day, I can totally explain that away, right? A kid who's drinking more and peeing more because they had a cold and maybe they're rehydrating themselves. But most families get to a point where they notice something just isn't right? That kid that's got great energy is really, really lethargic, maybe breathing heavily as a sign of acidosis building, and weight loss is another really big one. And because of that dehydration, that ketosis that causes that acidosis, the vomiting, it is an acute emergency. So this is one of our big endocrinology emergencies is DKA. So when kids come into the emergency room with these symptoms, our EDs and urgent cares are very good at recognizing the polyuria, polydipsia, nocturia, weight loss, fatigue, constellation being concerning for diabetes. We'll get that point of care blood sugar, and then we'll get a series of labs that help us to know whether or not they have metabolic acidosis as a function of DKA. So they'll get blood gases, and if we see a pH below 7.3, that's concerning for acidosis. They'll get probably serum and urine ketones. So if those are positive, that tells us why we're acidotic, and then that really high blood sugar over 200. And so hydration is a big mainstay because, again, these kids are very dehydrated. They've been urinating a lot, and then replacing their insulin via IV. So IV insulin is the initial treatment in addition to hydration. And what we do, because we don't want to correct that hyperglycemia too quickly because the body's very sensitive, particularly the brain, to osmotic changes, we want to slowly bring that hyperglycemia down to a safe place while replacing the electrolytes they've lost and the fluids that they've lost. So we do what's called a 2-bag system. So we're giving them IV insulin continuously, but we're titrating the amount of fluids that they're getting to make sure their blood sugar doesn't drop too quickly. We do that by balancing dextrose-containing fluids that have electrolyte replacement, as well as non-dextrose-containing fluids, and monitor labs, their clinical status very, very closely. Most kids are able to be on a normal, regular floor and don't need ICU-level care, but some kids who are very acidotic or maybe have other complications, other electrolyte abnormalities, or really young kids who can clinically change quickly, we put them in the ICU for safety.
Yeah. And the big thing that we worry about is cerebral edema, because as the glucose molecules disappear just from osmosis, you're going to get drawing of water from the plasma into the brain cells, and then you can have cerebral edema, herniation. So you really want to monitor for mental status changes.
Right.
And then is mannitol still used if you do have signs of cerebral edema?
Yes. So thankfully, it is not a common complication because we have such great studies to help us inform, again, that titration of glucose, how much fluid to give, because honestly, a lot of kids, the risk is increased based on their severity, but also if they're really rapidly changing those blood sugar levels. So we get very nervous if someone with a very high blood sugar comes down very quickly. And we have a very low threshold to do a CT scan, to do very, very close and frequent neuro exams, and then to give either 3% or mannitol as a treatment to manage.
Yeah. And what is the rate of coming down that's safe, that your goal would be?
Yeah, so we don't like to see that blood sugar change by more than like 50 to 100 milligrams per deciliter per hour.
Okay.
So while these kids are on that drip, they're getting hourly point of care blood sugars, and then the fluids are adjusted because we want it to come down, of course, but just again within that in that frame, in that range. And so we have an algorithm that we teach our residents who are on the floor taking care of our kids to know how to do that. And of course, we're available if they need assistance.
Yep.
They're getting Q2 do labs and electrolytes again to make sure we're going in the right direction there, because there are a lot of common electrolyte abnormalities such as hypokalemia that can occur and significant hypernatremia with that dehydration.
Yeah, absolutely. In terms of treatment, really things have evolved quite a bit in the last 10, 15 years. So that now when we're talking about long-term treatment, it's not just, injections with insulin as it used to be, but now we have pumps and we have monitoring devices, and the monitoring devices can talk to the pump and all of that. And it's really, I think, beyond the scope of this conversation, because we could spend an hour easily talking about insulin pumps, right? But just give us an overview if you could.
Yeah, absolutely. It's a really exciting time to treat diabetes, because while we don't have a cure, we have really great technology that's evolving the care and easing the burden for our patients and families. And so, as you had mentioned, insulin can be given by insulin pens as injections, or given by a pump, which is subcutaneous and changed out every 2 to 3 days. And so not only can you do that, you have adjunct therapies that help your care in terms of continuous glucose monitors, which are attached to your body, ranging anywhere between 10 and 14 days, and that continuously monitor your blood sugar and can remotely allow your caregivers to see how you're doing and what your trends of your blood sugars are if there's any acute care that's needed. In addition to that, now that we have reliable continuous glucose monitors and reliable pumps, which are always evolving, they have now spoken to each other. And now we have these pumps called hybrid closed loop systems, which allow the CGMs, or continuous glucose monitors, to speak to the pump and provide an algorithm to manage their blood sugars and allow their glucose to be more in range. There's some investigational studies on what we call a bionic pancreas, and it's still under investigational study, and it does not have FDA approval. However, this is a bionic pancreas that's even more automated, that allows more automation of the insulin delivery. And finally, there's islet transplantation that I know has been a buzz around research circles and patients and families. And there's islet and pancreas transplantation, which, of course, is an evolving area of research as well, which allows your islets cells that produce insulin to be transplanted. However, then you deal with the availability of beta cells, the risk of immunosuppression, and of course, unfortunately, cost.
Yeah, absolutely. And if whatever predisposed them to developing type 1 diabetes could also happen in the future with the new islet cells, correct?
Right. And so I think it's a very exciting time for this to happen. And there's also a lot of work in other forms of diabetes where they transplant auto islets. However, like you said, the immune process has to be mediated first, and managing the risks of the immune response and immunosuppression to deal
Which
with
is
that.
possible because as we think about drug allergies, a lot of people do outgrow their drug allergies if you test them 10, 20 years later. So, maybe those conditions aren't present anymore. And all that to say there's more to come.
Right, exactly.
In the future. I am going to include some more up-to-date links for folks in the show notes, the overview of the management of type 1 diabetes mellitus, insulin therapy for children and adolescents, and nutritional considerations in type 1 diabetes, because nutrition is also part of the management, right? We are able to add insulin, but if we also control how much glucose is going in or how many carbohydrates that are going in that turn into glucose, that's also important, right? So our nutritional colleagues are very important.
Yes, we have a multidisciplinary clinic, and we have a lot of ancillary staff that are integral to our diabetes care. And that includes our diabetes nurse educators, but as you had mentioned, our registered dietitians. And they provide a lot of comprehensive dietary guidance to our type 1 diabetes patients and our families. And while I'd like to add that, it's important to know when we teach our children with new onset type 1 diabetes to count their carbohydrates, to take the insulin as needed for their carbohydrate consumption, we also give them more general guidance on nutrition, because I think we used to say that patients with type 1 diabetes would usually be leaner, and we would give them more freedom on what they should eat. But we've kind of changed that perspective in saying that for children with type 1 diabetes, along with all other children, we should have a healthy outlook to our nutrition and our intake. And there are a lot of studies on low carb diets, which is beyond the scope of this talk. And like you had said, we probably could talk about that for a long time, but we do generally recommend that growing children get the nutrients and more global nutrition needs that require them throughout childhood.
Yeah, absolutely. I want to talk a little bit about the medical complications of type 1 diabetes, because as primary care physicians, we may have a patient that we know is a type 1 diabetic, and we want to be a resource for when parents have questions, when things, obviously, if they have an endocrinologist that's following them, you guys have, they're encouraged to call you, and you have nurse practitioners and others, who are able to help the families. But there may be times when they have a quick question in the office, or as a primary care provider, you are sort of screening for complications of diabetes. What are the things that we should be on the lookout for?
Yeah, so that's a great question. There are national and international guidelines on how we treat and screen our children for type 1 diabetes. And this is guided by the fact that there are known complications of type 1 diabetes, including neuropathy, retinopathy, and kidney disease, including cardiac disease as well. And this can also affect their school performance and behavior as well in school and beyond in adulthood. And so kids also with higher blood sugars can have poor wound healing, or if they're hospitalized, not be able to recover as well as they could with optimal blood sugars. So we do screen for things like urine microalbumin as an early marker for urine microalbumin and kidney disease. We also do lipid panels for screening, as well as eye screenings when they've had diabetes for a certain amount of time. Fortunately, our children are not seeing as many complications during that time period of their lives, and we see that later on in young adult or older adulthood.
Yeah. So the longer you have type 1 diabetes and the less control you have of that diabetes over long term can cause things like cardiovascular complications, neuropathies, skin ulcers and all those things. But fortunately for us in the pediatric world, that those complications tend to be more in adults, not exclusive, obviously.
Right.
But we don't see it in kids quite as much, correct?
We don't see it quite as much, but like you had made a great point is that not only is the duration of diabetes important, but it's also the control that you have. And so if you have a child that was diagnosed, for example, at 18 months of age or 2 years of age, and they had poor control for 2 decades of life, they may see unfortunately, some complications that you may not normally see later in adulthood at a younger age.
Yeah. And then the two big things that we would really watch for in terms of complications in kids is going to be diabetic ketoacidosis, because it can happen not only when you first are diagnosed, but especially if you have increased energy needs and like you're sick, for example, and your body might need more insulin and you're not providing it, that you could, your blood sugar could creep up. And so we also know that, when you're sick, you might have a sliding scale and might need more insulin under certain conditions. Or if you suddenly are involved in a sports and you hadn't been involved before, you might have different needs, right?
Yeah, so insulin needs vary greatly. Sometimes, definitely by the month, because we've got growing kids that are going through puberty, and their insulin needs, especially once they're initially diagnosed, change very, very greatly. People may be familiar with the term the honeymoon phase of diabetes. So this is the phase of diabetes early on where we're now giving exogenous insulin. So whatever remaining endogenous insulin the patient has is actually effective. So we have to back down on their doses. But as their disease progresses and they become essentially insulin deficient, their insulin needs are kind of established at a normal regimen. Yep. But like you mentioned, different parts of life and different activities and different types of things can change their insulin needs, particularly puberty for girls when they're going through their menses. And then illness. Illness makes us more ketone or more insulin resistant and gives us an increased propensity for ketosis, even if our blood sugars are normal. So the kid who's vomiting, having diarrhea, isn't eating that well, is going to have dehydration ketosis, but then also have ketosis because they have diabetes.
So from the primary care standpoint, this is when kids are sick, when there's changes happening like puberty, like maybe getting involved in sports. That's really going to be a time that you want to screen what their blood sugars are doing. And hopefully the family can tell you what the blood sugars are doing so that you have some awareness and can at least let them know, hey, you really need to talk to your endocrinologist, or no, this is normal and, it seems to be fine. Urine ketones too is really important for families to monitor during those times of change, right?
That's right. And so illness happens all the time. We're back in school, we're not masking anymore. So we're seeing our normal childhood illnesses. And so any fever, any cough, earache does give you a risk that your body's going to have an increased insulin need and need to check those ketones.
And if we're giving insulin, then we can sometimes give too much insulin, and that can drop our blood glucose lower. And so hypoglycemia would also be a complication of diabetes. What should we be watching for to make sure that that's not happening?
Yeah. So in general, we try to teach our families to recognize patterns. It's something that takes time and is part of the education that we give over time, but we want them to recognize when they're noticing frequency of either high blood sugars or low blood sugars. Because again, if they're in a sports season, if they've changed their diet, if, their growth has changed for some reason, they may have a lower insulin need and be more prone to low blood sugars. So physical activity, PE, recess, all those things do put kids at risk for having low blood sugar. So we counsel them at diagnosis with our therapeutic recreation team, and then at each appointment on things that could put them at risk for hypoglycemia, how to prevent hypoglycemia, and then how to appropriately treat hypoglycemia.
Yeah, all very important things. And I'll put a link in the show notes for the up-to-date article, Complications and Screening in Children and Adolescents with Type 1 Diabetes Mellitus. So there's just so many resources and so much more that we could say. And if if folks are interested in taking a way deeper dive, we'll have those resources available in the show notes. Now, you had mentioned that it's not only physical complications that are possible, but mental health complications and psychosocial complications are also common in type 1 diabetes. And here is a place where the primary care provider really can do a great job at screening and getting folks plugged into the help that they need as quickly as possible. But what are some of those psychosocial complications of type 1 diabetes that we should be on the lookout for?
Yeah, so having any chronic condition is really tough for a kid. And as we mentioned, most kids the average age of diagnosis is 12 to 14. So that really tender, challenging time of life where you're entering adolescence and teenager, which is already something that's really challenging for kids. So many kids do struggle with depression, do struggle with anxiety, and may struggle with accepting their diagnosis and incorporating it into their life, because diabetes doesn't care that your parents just got divorced or that your grandma just died, right? Sometimes it can happen at a time of big stress or in someone that already maybe was struggling with other conditions or other mental health challenges, social determinants of health, other toxic stress. So all that to say, a lot of people do struggle with diabetes, and even those who are well-adjusted. It's a huge diagnosis. As we talked about, I think it's clear that it requires a lot of work and a lot of communication and a lot of change in daily life, but it is manageable. We do know the prevalence of depression is higher and the prevalence of depressive symptoms are higher in patients with type 1 diabetes. Diabetes Care, which is a great publication from the American Diabetes Association, published a paper last year that indicated that about 30% of patients with type 1 diabetes have depressive symptoms and about 11% meet the clinical diagnosis of depression. And that there's about a 3 times higher prevalence as matched compared to same age peers in terms of depression. So we know that, kids are susceptible to depression. Globally, we're seeing, regardless of health history, an increase in anxiety and depression, but we do know that these kids are at higher risk.
Yeah. And so if there are changes in a kid's demeanor, and if parents are kind of clued into this, or there's a change in behavioral problems, schoolwork problems, problems with friends, really anything that gets your parent the radar up that there's an issue, definitely bring that up. And us as primary care providers can be screening and asking about those things.
Yeah, that's right. And another thing that we see is, everyone's relationship to their diabetes is different. Some kids run to school, especially our little ones, with a book about diabetes and their bear that they learned how to give injections on and are so happy to show their friends their Dexcom. And some people would rather rather nobody ever know. So withdrawal, changing their social engagement, not doing things that they were doing before can all be subtle signs that somebody is really struggling. And again, may not meet criteria for depression, but may just have this kind of very specific disease relationship that really is making their life challenging.
And we've said this on PediaCast, both the parent program and our CME program many times, that asking kids about if they've had thoughts of hurting themselves or thoughts of suicide, asking them about that is not going to put that idea in their head. And there's not an increased risk of suicide if you talk about it. On the other hand, if you talk about it and get folks the help that they need when they need it, then there is less chance that a kid could, have a tragic outcome. And so definitely if a kid has signs of depression, that should be part of the screening. Have you had thoughts of hurting yourself?
Exactly. And we do the PHQ-9 screening, and we have social work available with us in clinic that if we have any concerning single answers or total scores that indicate a child is at risk for harm, we engage them immediately, and they do a fantastic job of meeting families where they are, being empathetic, and getting them the resources they need, whether that's a safety plan hooked up with counseling or in some cases, a trip to the behavioral health pavilions for more acute care. Yeah,
absolutely. You'd mentioned, and we have been mentioning, that both endocrinologists and primary care physicians have a role in supporting families that are challenged by type 1 diabetes. I would say there was a day when a lot of pediatricians it was sort of a point of pride, like I take care of my own diabetic patients. But we're at a point now, really, where it's such a multidisciplinary team approach. And there's people who are experts at nutrition and people who are experts at following the blood sugars and making sure the screenings are happening, that really pediatric endocrinology, I think, ought to be involved in the care of all of these patients. I'm sure you probably agree with that.
Yeah, and I do agree. I think especially in places that are challenged for resources, that there are some people that probably have had experience and probably do a great job of taking care of their patients. However, because of all of the complexities and the need for all of the different supports, care is multidisciplinary. I tell my patients all the time, diabetes is a team sport. So you really need that team of having a, board certified endocrinologist or an advanced practitioner who has special skills for diabetes care, that registered dietitian, social worker, and diabetes nurse educator. Yeah. And the ADA and ISPAD both advocate that the care of type 1 diabetes be overseen by an endocrinologist.
There's a large proportion of the U.S. population that is, several hours drive away from their nearest pediatric facility. But it's such an important thing. Is telemedicine helping rural providers maybe manage those patients a little better?
So we do offer some telemedicine services and some appointments within our clinic space. The majority of our appointments are in person because there are a lot of things that we do need to do. Check your injection sites, height, weight, all of those things. However, for intermittent care, telemedicine is actually a great option for diabetes because we can upload your blood sugars. You can send us your logs. We can talk through all the different things that you need to do. So that in-person care is vitally important, but there absolutely is a role for augmenting that with telemedicine care, especially for our families that do live very far away from us.
Yeah, that totally makes sense. Here at Nationwide Children's Hospital, we have a lot of projects going on to support patients and families who are impacted by type 1 diabetes. QI projects, we think about equity and making sure that all kids with type 1 diabetes get the same excellent care, programs to educate families on diabetes. Dr. Gandhi, tell us a little bit more about those sort of programs here at Nationwide Children's Hospital.
Yes, thank you. I think that's a great question. Our diabetes team is very honored to treat our children with type 1 and type 1 diabetes. And because type 1 diabetes, as Dr. Wood mentioned, is a chronic lifelong illness and it's a team sport, they experience unique challenges throughout life and adulthood. And so we have lots of projects that address those specific issues throughout their childhood. And so our comprehensive diabetes team, as we had mentioned before, consists of our diabetes medical provider, our diabetes nurse educators, and our clinical staff, which includes our registered dietitians, our social workers, and our diabetes nurses. We offer regular educational opportunities in the community as well as in our clinic for ongoing common diabetes care, diabetes technology, and offer resources for different aspects of diabetes care. But as you had mentioned, we have a robust quality improvement initiative that offers various aspects of diabetes care that we can improve on. And so one of the ongoing projects that we're doing is an equity-based quality improvement project, which allows us to improve the percentage of patients who are from minority populations, increase their access to some of that life-changing diabetes technology and care and access, which we have been successful in these last few years, but we do have quite a bit of work to do. And that is part of a greater institutional initiative to improve equity amongst all different types of medical conditions.
Is it difficult to get insurances to pay for the continuous glucose monitoring and the pumps, or is it? I mean, you think it would be at the point where that would be the standard of care that everybody should get?
Yeah, you would think so. But yes, we've had lots of challenges getting our families to access those life-changing diabetes technology, namely continuous glucose monitors, which whether they want to be on an insulin pump or not is definitely their choice, which can improve their care, of course, but a continuous glucose monitors can be life-saving, where you can acutely catch a hypoglycemia before it even happens, or hyperglycemia before they could progress to DKA or ketosis. Yeah. And they can monitor it remotely from the school, and it improves their school care, improves their home care, and it helps different caregivers get access to that child's care. And so over I would say 10 years, fortunately, we've had increasing advocacy for improving that access with our patients with public insurance. And so, but it's still an ongoing struggle and advocacy nationally as well.
Yeah. From the insurance point of view, you would think they would understand that if you have tighter control over a long period of time, it's the long game, but you're going to also then hopefully have less that you have to cover for the treatment of cardiovascular disease, right, and the chronic health problems that can go along with diabetes. So paying a little more now can save you a lot of money later. That's the thinking, right?
Yes, and I think because this diabetes technology is relatively new, we don't have that. We have a lot of robust short-term data that says that improves outcomes, but because we don't have that long-term data potentially for, like you said, complications, is that allowing us not to be able to prescribe it? I don't think that should be a barrier. However, that is something that we don't have yet, but we should. We're hopeful that that long-term data is going to show the same thing.
It'll be very interesting for sure. Also, of course, education is a big part of diabetes care, and the more health literacy that we have about the management of diabetes, that to empower families to make good decisions is really important. And in that vein, the three of us did a podcast on our parent podcast, Plain PediaCast, about diabetes. It was episode 522. And so for folks who have families challenged by diabetes in their practice, please mention that to them, episode 522, and I'll put a link in the show notes for that as well. But that'll be a good one for families to listen to. We talked about viruses being one of those associated things with the onset of type 1 diabetes, because there's this autoimmune component. So we recently had a fairly large viral event in the world called the COVID-19 pandemic. And have you seen an increase in type 1 diabetes as a result of COVID?
Yeah, that's a great question. And it's actually an evolving question. And there's ongoing research studies that keep getting published about it. But we have seen preliminary studies showing increases in incidences, prevalence, of course, and actually the lack of seasonal variability in type 1 diabetes. We would mention viruses happening more so in the winter months because of that seasonal variability of type 1 diabetes, but COVID-19 actually showed that it increased in all aspects. Not only that, it actually produced severe complications in our type 1 diabetes patients that may not have been in optimal glucose control and producing complications.
Yeah, in terms of more severe COVID disease. Mm-hmm. In the pediatric population as well? I mean, probably not to the degree as in the adult world, but you have seen some of that.
Absolutely. And we saw it here in the hospital, as well as we were seeing it in published studies as well. The more suboptimal glycemic control that these patients had, the more severe COVID-19 disease that they had. And we saw it also in our newly diagnosed type 1 diabetes patients, because of course they were in suboptimal glycemic control because they were not aware.
Yeah. And that goes back to your glycemic control having an influence on your immune system's ability to fight infections, even though it might have been an infection that started the whole ball rolling to begin with.
Right.
Just to show you how complicated this is.
Right. And so is there an immune-mediated response and association with COVID and type 1 diabetes diagnosis? And there was a lot of ethnic and racial disparities that we actually were exacerbated with the onset of DKA and lack of diabetes care and access during COVID-19 pandemic as well.
Yeah. Kids spend a lot of their time at school. When you consider, that's a big chunk of time. And so it's, I think, important for schools to also be supportive of patients and families when they have diabetes. So, Dr. Wood, what exactly is the role of schools in helping these kids? And then that'll lead us into talking about the Diabetes Dash program.
Yeah. So as you mentioned, kids spend about 80% of their time at school. So that includes for many kids at least lunch, but for some kids, they may have breakfast or a snack. They'll be exercising. They might have PE. They may be off campus at different times. So as we've talked about, management of diabetes includes constant glucose monitoring to make sure kids aren't at risk of complications, that they're getting the proper insulin that they need for carbohydrates, and that if they're sick or something changes, that someone knows how to attend to those things. So during those 8 to 10 hours when kids are at school, that does fall on the school staff and nurses. So thankfully, many schools and school districts have nurses who are trained in diabetes care. However, as we know, school is very busy and there can be hundreds of children with different medical backgrounds, in addition to the coughs, the colds, the bad headaches and things. So schools are very strapped in terms of resources and time, but do play such a vital role in helping us take care of our kids with the school nurse or that school staff that's trained is the person the kid goes to at lunch with their carb count from their meal, and they do their insulin together. And then make the plans for all those other contingencies. And we, as the diabetes team, help them by sending them what we call our diabetes school orders, which outline how to treat their blood sugars, how to give their insulin for their carbs, and then what to do during times of low or high blood sugar. Yeah. We can also add in additional supports and recommendations based on the kid's experience. So if there's a kid who has a lunch and then recess and then gym right after that, we know they're probably going to need a couple extra blood sugar checks because they're at risk of hypoglycemia, getting insulin, and being really active. Yeah. Yeah. So we can advise them on different things like that, as well as how to utilize their pumps and CGMs during their school day.
Yeah. Then that leads into this program that you guys have started called Diabetes in School Health, which is the Diabetes Dash program. How is that different than just the school nurse helping these kids and families? Yeah,
so the Diabetes in School Health program is a new health equity school-based health program that we started last year within the Department of Community Wellness, where all of Nationwide's school health programs are located. So in addition to seeing us in clinic every 3 months, which we do with our diabetes team, the patients and students as well as the school staff now have an additional monthly support. So what our program entails is the kids get their medications and supplies couriered to their school and their home to remove that barrier of not having supplies, not having access to things they need, as well as providing one-on-one education, support, and guidance in the school setting. So we have a nurse practitioner and 2 diabetes nurse educators who meet with our students monthly to go over their diabetes care. They'll download their pump or their CGM, they'll review their blood sugars, make adjustments based on their patterns, and then they'll just teach them and talk about how's your diabetes going. A lot of that includes psychosocial support and kind of talking through all those different things that we mentioned a little bit earlier. And a lot of that includes just helping them feel more independent and in tune with their diabetes care.
So this is an actual clinic in the school that is staffed by Nationwide Children's Hospital staff members.
So 13 different schools within the Central Ohio do have actual nationwide school-based clinics. But for those that don't, because we have students across more than 50 schools at this point. They meet in a specific place to do that education and training. So it may be a special place in the nurse's office. It may be a quiet conference room in the library, but they find and designate a place ahead of time during a period where the child is able to be away from school and not take away from their education, to have this about 30 to 60 minute meeting to go over all these different things and help the kid to optimize their care and learn more about their diabetes, in addition to getting their insulin and having their blood sugar checks with the nursing staff.
Yeah. I mean, I love this because I imagine that this began with a group of people in your division that are like, how can we make diabetes care better? Like, how can we really meet the families where they are? And since kids spend so much time at school, making that a part of it, and then finding the funding to do that, and then the manpower of putting it all together. I just think it's an awesome program that you guys have designed.
Thank you. And it's really a testament to our team in school health who have been amazing in supporting the program, and our collaborators across the institution.
Now, we're an academic institution, and so there's also going to be, as we do programs like this, we want to publish and let the world know what we're doing and whether it's working or not. Do we have any indications that these kids who are involved in the Diabetes Dash program have better outcomes?
Yeah, so for this pilot year, we wanted to start with the kids that were the most vulnerable and needed us the most. So we identified those kids using our diabetes composite score, which is a novel tool that we developed here with our QI team here at Nationwide developed in order to get a more comprehensive evaluation of how well someone's diabetes is being managed. And so for this first year, we wanted to identify those kids who had the lowest score, which indicated they were at the highest risk. So our goals for those kids was to improve their, again, like some psychosocial outcomes, their efficacy with their diabetes care, helping them to get to their clinics, helping to identify those different things that are making their diabetes care challenging. So we are monitoring their A1C, their different lab results, their use of technology. So if they're using a CGM or a pump, as well as just their overall diabetes care skills. So we have kind of a set amount of objective and subjective data that we're collecting. What I didn't mention earlier is that another big part of this program is education for the school staff. So as we've mentioned, diabetes care is rapidly changing, and these technologies can be very confusing and feel overwhelming for someone that doesn't use them every day. So our amazing clinical team does formal and informal district and statewide education for nursing staff so that everyone feels comfortable with diabetes care. So that's another thing that we're actually monitoring and tracking using some standardized tools, is how well school staff and nurses feel and their comfort in managing diabetes and their type 1 diabetes education. The outcomes that we've seen have been really encouraging our first pilot year. So 2021 to 2022 school year was our first year. So we wanted to start with 50 students. That was kind of within the capability of our team in Central Ohio who attend a school that's within 45 miles. That way our team could be able to spend that good amount of time with every student every month feasibly. And they completed over 150 visits that first year. And the outcomes that we are the most proud of are the psychosocial outcomes. The kids who were just withdrawn, who were just angry about having diabetes, now opening up, talking about their diabetes, being more engaged. The parents noticing that, getting them hooked up with the other school health programs. So since we have lab, we can do those routine screening labs that we need to do. Since we have primary care, we can get them their immunizations if they're not up to date. They can go to the dental clinic. So really doing that comprehensive care. But then also the biggest thing that we've seen data-wise is the use of CGM. So at the beginning of our program, only 13% of our students were using CGMs regularly, and now about 45% of them do. Yeah. So more to come. We've definitely shared our successes and the basis of the program, both nationally and internationally at diabetes conferences, but we are working on our first publication to go through the details of all of our data.
Yeah, that is great. And really, when you think about that, this just started in 2021 and you have all of these sites, it has just really ramped up so quickly. So Dr. Gandhi, what does the future look like for the Diabetes Dash program?
Yeah, so very exciting. And as you had mentioned, we have grown quite a bit in the last year and a half. And we actually have, because of the immense success that we're so fortunate to have, we have school nurses actually reaching out to us saying, hey, we have this patient or we have this child or student that's really struggling. Can we have them? And so we have a long list of students that we hope to include over time. So over the next 3 to 5 years, we hope to expand our student base. We hope to expand our staff with inclusion of more diabetes nurse practitioners, diabetes nurse educators, to serve a greater population in Central Ohio and increase our reach. As well as increasing our concentration at some of the high-risk students within the Columbus area as well. We also hope to expand our program, not only just to type 1 diabetes, but maybe to our type 2 diabetes programs, to collaborate with sports medicine or healthy weight and nutrition clinic to tackle healthy behaviors, and that because that affects type 2 and type 1 diabetes patients as well. We're increasing, as she had mentioned, mental health is very, very important, not only just at home, in our clinic, but also in school because they spend so much time at school. So we're hoping to have more collaboration within our school health program here at Nationwide Children's with increased behavioral and psychosocial support with social workers and our behavioral health pavilion. We are also doing a lot of exciting educational events, and we hope to collaborate more with the school nurses and the school nurse conferences and doing something that helps collaborate and provide information over a greater amount of people.
Yeah. Is this something that other places around the country are starting to do as well?
They are. I think it's a very innovative concept that I feel that we are one of the few programs that we know of that are doing type 1 diabetes care actually in the school. All large pediatric programs do collaborate with the schools because, of course, that is so important. We do know of 1 or 2 programs that are doing formal programs in the schools, but it is a new area of study and a new area of intervention that we hope to change.
Yeah. I don't want your email boxes to get blown up, but if there are endocrinologists, pediatric endocrinologists out there at other institutions, and you're like, wait, that sounds like a really cool program, I'm sure you'd be happy if they emailed you and just said, how did you do it?
Yeah, we'd be happy to collaborate and share our data and, share what we've learned and, make this accessible to a lot of patients across the country.
Yeah. All right. Well, we really appreciate both of you stopping in and chatting with us about type 1 diabetes. I wanted to mention in the show notes, we're going to have like a ton of resources for folks. All the things that we've been mentioning, all those up-to-date articles. We also have links from Diabetes and School Health, the DASH program, endocrinology here at Nationwide Children's, but also the American Diabetes Association, the Juvenile Diabetes Research Foundation, type 1 diabetes info from the CDC. And you had mentioned ISPAD?
That's right.
ISPAD.
ISPAD, yep.
Yes, and we'll put a link to their resources in the show notes as well. But before we go, Dr. Wood, tell us a little bit more about endocrinology here. You guys aren't just about type 1 diabetes. You take care of lots of different things.
Yeah, that's right. So we've mentioned we take care of kids with all types of diabetes, so type 2 diabetes, the kids that do have the genetic forms of diabetes, but of course we treat any endocrinopathy. So that could be anything related to pituitary health, thyroid health, bone disease, growth, puberty disorders, you name it. These could be primary endocrine concerns. So someone that, again, maybe has type 1 diabetes and was just predisposed. Someone that was born with septo-optic dysplasia and now is panhypopit. Or someone that maybe had an iatrogenic endocrinopathy, so maybe on high-dose steroids and now has adrenal insufficiency, or someone who had another condition that predisposed them to diabetes. So we are quite a busy service. We are quite a busy clinic. In our outpatient settings, in addition to our diabetes clinics and our endocrine clinics, we have a couple of multidisciplinary clinics as well. So one of those is our PCOS clinic, where we take care of young ladies with polycystic ovarian syndrome. We have a type 2 diabetes clinic because we want to make sure we're giving them the standard of care, which is a bit nuanced as compared to type 1 diabetes. We have the Thrive Clinic, where we take care of our gender diverse patients and patients with disorders of sexual development. We have a clinic, our CFRD, so cystic fibrosis related diabetes clinic. And then we have clinics related to specific genetic disorders such as Prader-Willi 22q. So those are all multidisciplinary that we work with other sections and specialties as well as other ancillary staff. In the inpatient setting, we admit our own patients to our service, and we have a very robust consult service where we help take care of kids across the hospital that have different endocrinopathies or different endocrine concerns that may be contributing to why they're admitted at the hospital. We also have a couple special inpatient services, one being DISC, which is a new team which provides care for kids that are in the hospital for another reason but have diabetes and need someone to make sure that's being well attended while they're there. So that service provides great care for us across the hospital in our behavioral health pavilion and really do a great job helping us take care of those kids. And then we have a new program called TPIAT, which Dr. Gandhi could probably tell us a little bit more about, but that's total pancreatectomy islet auto transplant in coordination with surgery, GI, and multiple other specialties.
That sounds like a whole nother podcast.
Yes, it's an emerging service that has started in the last year, and it's geared towards the multidisciplinary care that's related to patients who suffer from chronic pancreatitis and ultimately have pancreatic-related diabetes.
Very interesting. So all of that to say, you guys are really busy.
Yes,
and that makes it even that we're as a podcast audience just so appreciative of you taking time out of your very busy schedules to stop by and talk to us. And we'll have to figure out something for 2023.
Yeah,
absolutely.
Yes.
We'll always have lots of exciting info to share.
Yeah, absolutely. So once again, Dr. Aurelia Wood and Dr. Kajal Gandhi, both pediatric endocrinologists at Nationwide Children's Hospital, thank you so much for being here today.
Thank you so much.
Thanks for having us.
We are back with just enough time to say thanks once again to all of you for taking time out of your day and making PediaCast CME a part of it. Really do appreciate that. Also, thanks again to our guests this week, Dr. Aurelia Wood and Dr. Kajal Gandhi, both pediatric endocrinologists at Nationwide Children's Hospital. Don't forget, you can find us wherever podcasts are found. We're in the Apple and Google podcast apps, iHeartRadio, Spotify, SoundCloud, Amazon Music, and most other podcast apps for iOS and Android. Our landing site is PediaCastCME.org. You'll find our entire archive of past programs there, along with show notes for each of the episodes, CME information, our terms of use agreement, and that handy contact page if you would like to suggest a future topic for the show. Reviews are helpful wherever you get your podcasts. We always appreciate when you share your thoughts about the show. And we love connecting with you on social media. You'll find us on Facebook, Twitter, LinkedIn, and Instagram. Simply search for PediaCast. So you've listened to the podcast. Now be sure to claim your free Category 1 continuing medical education. Really easy to do. Just head over to the show notes for this episode 81 over at PediaCastCME.org. You'll find a link to the post-test in the show notes. Follow that link to Cloud CME, take and pass the post-test, and the Category 1 credit is yours. Super easy, right? And again, we offer credit to many pediatric professionals, including doctors, nurse practitioners, physician assistants, nurses, pharmacists, psychologists, social workers, and dentists. Of course, you'll want to be sure the content of this episode matches your scope of practice. Complete details are available at PediaCastCME.org. Also, I want to remind you about PediaCast. That's our evidence-based podcast for moms and dads. Lots of pediatricians and other providers also tune in as we cover pediatric news, answer listener questions, and interview pediatric and parenting experts. Shows are available at the landing site for that program, PediaCast.org. Also available wherever podcasts are found. Simply search for PediaCast. Thanks again for stopping by, and until next time, this is Dr. Mike saying stay informed, keep it evidence-based, and take care of those kids. So long, everybody.
This program is a production of Nationwide Children's. Thanks for listening. We'll see you next time on PediaCast CME.